and welcome to the first of two lectures on medications used in diabetic patients. This first lecture we will be talking about the pharmacotherapy of the oral antidiabetic agents. Again, as with several other lectures throughout this course, I'm assuming that you have baseline knowledge of the pathophysiology and disease state of diabetes. So the lecture material will not cover diagnosis and glycemic goals in detail. I would refer you to the American Diabetes Association guidelines for full review if these are issues that you're not comfortable with. What you should be able to do is assess a patient and know what medication they need and know how these medications work in certain populations that you shouldn't use some of these agents in. So that kind of helps narrow your focus a little bit. As mentioned, interpreting appropriateness for a drug therapy assumes that you do have some baseline knowledge of the treatment guidelines, goals, and monitoring. So refer to the link off of the module to the American Diabetes Association guidelines if you need to review those to help understand some of the pharmacotherapy topics that we'll be covering in this discussion. Your learning goal for this lecture should be to become familiar with the pharmacology of the oral antidiabetic agents. And we're going to focus on the mechanism of action, or how these agents work, the appropriate use of these agents, as well as inappropriate use or patient populations in whom they should be avoided, cautions when using these agents, as well as adverse reactions that you'll need to counsel your patients on. In order to help keep things understandable and organized in a way that you can group drugs together, we are going to classify these agents by how they work. So we'll start off by talking about drugs that improve insulin secretion, and in that class of agents we have the sulfonylureas and the maclidonides. And we'll also talk about drugs that improve the action of the patient's own endogenous insulin. And agents that do this include metformin and the thiazolidinedinones, or sometimes called the glidazones or TZDs. I promise I won't refer to them as the thiazolidinedinones for the entire lecture, otherwise my tongue would go crazy on you. It would be all twisted. So I'll probably refer to them as the TZDs. We'll also be discussing drugs that modify intestinal absorption, and under this mechanism falls the alpha-glucosidase inhibitors. And finally, we'll be discussing what is the newest novel mechanism of action within the oral antidiabetic agents, and that's the dipeptyl peptidase 4, or DPP4 inhibitor, sitagliptin. So starting off with a class that improves insulin secretion, we'll begin with the sulfonylureas. There's a few assumptions that you have to make if you're going to use an agent that improves insulin secretion. And the first and foremost is it assumes that you do have some basal pancreas function left so that we can actually cause insulin to be secreted. If you don't have this, you can see that these agents really aren't going to do your patient any good. So for obvious reasons, these are not for type 1 diabetics, these are for type 2 diabetics. How these agents work is listed for you here. The receptor is a component of the ATP-dependent potassium channels in the islet cells of the pancreas. And so binding to this receptor, as these agents do, alters the cell resting potential and allows for calcium influx into the cell. And this change stimulates insulin secretion from the beta cells. In addition to this mechanism of action, the sulfonylureas also improve insulin sensitivity at the receptor and post-receptor levels. And a third mechanism is that they decrease hepatic glucose output. So really a few different targets for overall glycemic control with these agents. For patients on sulfonylureas, a general hemoglobin A1C decrease is about 1 to 2%. Now I'm going to be referring to HbA1c decreases for each of the classes throughout this lecture, and realize that this is really average data. You may see patients who don't respond to these agents at all, and you may see patients that have a greater improvement, but as I talk numbers and decreases in HbA1c and fasting plasma glucose, please keep in mind that these are all just averages. Of note, the sulfonylureas are hepatically metabolized, and some of the agents do have active metabolites, including chlorpropamide and tolazamide. One important point that I want you to remember is that glyburide and tolazamide may accumulate in patients with renal dysfunction, which we classify for these purposes as creatinine clearance less than 30. And the reason for this is these are 50% renally eliminated, and as you can see, tolazamide does have an active metabolite. So if we're prolonging the half-life of these agents in patients with renal impairment, we're increasing the risk of hypoglycemia from these agents, because hypoglycemia is a side effect associated with the sulfonylureas. In addition to just regular renal dysfunction patients, you have to consider your elderly patients who by age alone may have a decline in renal function. So the prolonged half-life of these agents, as I mentioned, may increase their risk for hypoglycemia. And for this reason, glipizide is the agent, the sulfonylurea agent of choice for this population. And the reason for this is it's only 10% renally cleared and has a shorter half-life. And as with any medication for your elderly patients, you want to start with a low dose and titrate slowly based upon response while monitoring for adverse events. So some of the adverse drug reactions and side effects that we're monitoring for include hypoglycemia, as I previously mentioned. It's important that patients are able to eat when they take their sulfonylurea. If they take their sulfonylurea and aren't eating regularly, obviously they run an increased risk of hypoglycemia. In addition, there have been some dermatologic reactions associated with this class of medications, and in part that's due to the sulfa component. Sulfonol obviously indicates the presence of a sulfur component, and we know that with our antibacterials that have a sulfa component, like the sulfonamides, there's been rash associated with those, as well as photosensitivity. So again, it's a counseling point to make sure that if your patient burns easily, they should be aware that this can increase the risk for photosensitivity. That being said, patients who are allergic to sulfa antibiotics may still tolerate a sulfonylurea. You'd have to definitely do a risk-benefit in someone who has an anaphylactic type reaction to a sulfonamide antibiotic on whether you would want to prescribe a sulfonylurea or go to a different class first. Also, these agents can cause GI upset as well as weight gain. And the weight gain in a diabetic patient, as you can imagine, can actually be detrimental to control. So that's one of the negative sides of these agents. While they do have good glycemic control and reduce that A1C 1 to 2% on average, if the patients are gaining weight, they may lose a little bit of control simply by weight gain alone. There definitely are certain patients who should not be prescribed a sulfonylurea. First and foremost, type 1 diabetics, as we already discussed. These agents assume that you have basal pancreatic function that isn't present in a type 1 diabetic, or patients in DKA. Patients with frequent episodes of hypoglycemia, this probably isn't the best choice for them, since hypoglycemia is a side effect or adverse reaction from sulfonylureas. If a patient is in a high-stress condition, such as an infection, hospitalization, etc., sulfonylureas may provide inadequate coverage. Acutely, insulin should be used to manage the patient, and they can be converted back to their oral agent once the high-stress condition has passed. And I alluded to this already, but patients who don't eat regularly are at risk for the hypoglycemia associated with the sulfonylureas. You should counsel your patient ideally to take their sulfonylurea 30 minutes prior to a meal. And if they're not going to eat, that's the instance where they probably shouldn't take their sulfonylurea, as their risk for hypoglycemia is severely raised if they're not taking it prior to a meal. A second class of agents that work by improving insulin secretion are the meglitinides. And in this class you'll find repaglinide and nataglinide. Now, while these agents are structurally different than the sulfonylureas, they don't contain that sulfa component, they do act in a similar manner on that same ATP-dependent potassium channel in the beta cells, and this results then in an increased insulin secretion. So for this reason, you can see that you do again assume that the patient has basal pancreatic function. So if you don't have that, these agents aren't going to do your patient any good. Their effect is similar to that of sulfonylureas, and they can be tried in those patients with severe sulfonamide allergies. So since there's no sulfa component, we're not at all worried about cross-sensitivity. As I did mention, if someone just has a mild type allergy to a sulfonamide antibiotic, such as a rash without hives, sulfonylureas usually are tolerated. However, these would be another option for you to use in those patients as well. You can see here the average A1C reductions for repaglinide about 0.5 to 1% and nataglinide about 0.6 to 0.8%. So while these don't have the same degree on the whole of reduction of A1C as the sulfonylureas, they are another option in certain patient populations. The meglitinides work well at decreasing postprandial blood glucose, but they have limited effect on fasting glucose. And they also have a similar adverse effect profile as the sulfonylureas, including weight gain, which we talked about some of the concerns with that earlier, and hypoglycemia. Regarding the pharmacokinetic parameters of the meglitinides, they're extensively protein bound and they are metabolized by cytochrome P450 3A4. So you can see for this reason that drugs that inhibit 3A4 may increase meglitinide concentrations, and the obvious issue with that is increasing the drug concentrations may make the patient more at risk for hypoglycemia. Conversely, drugs that induce 3A4 may increase metabolism of the meglitinides, and thus you may lose glycemic control and have an increased risk for hyperglycemia. You can see that the patients who should not get a meglitinide are very similar to those who shouldn't get a sulfonylurea. Since we're assuming basal pancreatic function for these agents to work, they wouldn't be good agents in patients with type 1 diabetes. And since hypoglycemia is a risk factor for these agents, patients who don't eat consistently and patients with frequent episodes of hypoglycemia probably are better served by other agents, which we'll talk about subsequently in this lecture. We should avoid these in high-stress situations for the same reasons that we mentioned for the sulfonylureas, and since these are hepatically metabolized, patients with moderate to severe hepatic dysfunction shouldn't receive these agents. Moving now from agents that increase the secretion of insulin from the pancreas, we're going to now discuss an agent that improves endogenous insulin function, and that's metformin. Metformin is a biguanide that has all of these great properties listed for you here. It acts, or its mechanism of action, is threefold. It reduces hepatic glucose production, reduces intestinal glucose absorption, and increases insulin sensitivity to the body's endogenous circulating insulin. It does not increase insulin resistance, it does not cause weight gain, and in some studies there's actually weight loss associated with this agent, especially in the initial titration phases when patients may have some GI upset. But on the whole, it's very weight neutral or maybe even with some weight loss. And as monotherapy, it does not promote hypoglycemia. So that's one big difference between this class and the ones that we have already talked about, is there's no hypoglycemia or weight gain associated with it. Metformin on average lowers fasting blood sugars by about 20% and decreases the A1C by about 1 to 2%, so similar to the sulfonylureas in its effect on A1C. It is available in combination products, combining metformin with a sulfonylurea and a TZD. Now, when you put these agents in combination with metformin, even though earlier I said metformin doesn't cause hypoglycemia, when you combine it in a single therapy with an agent that can cause hypoglycemia, it's obviously something that you still need to monitor for, as the hypoglycemia can be due to the non-metformin component. One interesting point that you'll probably learn a little bit more about in the Men and Women's Health module is that metformin has been used to treat polycystic ovary syndrome, or PCOS. And really, 40 to 70% of PCOS patients have hyperinsulinemia, leading to increased androgen levels. So that's how metformin targets that hyperinsulinemia. But that's not necessarily something that I would worry about for the purposes of this week's quiz. Just kind of an interesting point that you may see non-diabetic patients on this agent. One thing to point out is that with prolonged use, due to some malabsorption issues, you may see your patients have decreased B12 levels. So it's probably worth monitoring just to make sure that if you need to supplement your patient, you're recognizing that. Unfortunately, the most common side effects are gastrointestinal related, which can sometimes decrease the buy-in from your patient to want to comply with this therapy. Anorexia and nausea are often present over the first few weeks of titration, but they typically do tolerate out after the first 2 weeks to 1 month of therapy. So if you can counsel your patients through that initial titration phase and start them on a lower dose, 500 milligrams BID, and titrate them up after a week or two, that really helps rather than just blasting them with the full target dose from day one. Now, you would think that an agent that's weight neutral or has some weight loss associated with it, as well as an agent that doesn't cause hypoglycemia, would be perfect for everybody, but unfortunately it's not that easy, and there are certain patients and situations where we need to avoid the use of metformin. Again, obviously, type 1 diabetics, since metformin is relying on the patient to have endogenous insulin, it wouldn't be appropriate in a type 1 diabetic patient. Also, there's some strict prescribing criteria as it relates to renal function for this agent. Metformin is contraindicated when the serum creatinine is greater than or equal to 1.4 in a woman or greater than or equal to 1.5 in a man. And those are numbers that you should know, because patients that have serum creatinines over those values should not be prescribed metformin. Similarly, patients who have conditions that predispose them to hypoxemia, which then can lead to decreased renal perfusion, should be avoided, should not be prescribed metformin. And those are patients with acute heart failure, septicemia, metabolic acidosis, and acute myocardial infarction. The reason behind all of this is anytime that there's an alteration in renal function, we're increasing the risk for a metabolic acidosis due to metformin. It causes a renal tubular acidosis in some cases, and the risk increases when there's other renal risk factors present. And that's why it's also important for this last bullet to be stuck in your brain when you're counseling patients on their metformin. Metformin needs to be held for 48 hours pre and post radiology and cardiology studies that use iodinated dye. And you will probably remember, and those of you who have practice experience in these types of settings, that those dyes can be nephrotoxic. And usually that's a reversible acute nephrotoxicity, so the potential for acute alteration in renal function is there. So what we like to try to do is get the metformin out of the system for a couple of days and not introduce it until we know that the renal function is recovered. Now, that being said, if post-dye study your patient's renal function does not recover to the serum creatinine values listed above, then you should hold metformin as long as it takes for their kidneys to recover. So the 48 hours pre and post is somewhat of an arbitrary number. 48 hours pre I would hold to, but post you want to make sure to hold that metformin until you've reassessed their renal function, realizing that it could be up to 1 to 2 days until you see the detrimental effect from the dye. Describing a little bit more in detail the signs and symptoms of lactic acidosis that can occur from metformin, it is a rare occurrence, but as I mentioned, it's an increased risk in anything that's causing any sort of additional nephrotoxicity or decreased renal perfusion. Therefore, there's an increased risk in any heart failure patient requiring pharmacologic intervention, because those folks usually are to the point of renal hypoperfusion. Metformin is substantially renally excreted, and so if patients do have renal impairment, it can retain in the body and increase the risk of acidosis, which is why it should be used with caution or avoided in patients greater than 80 years old, simply because of that age-related renal impairment. A second group of agents that work by improving the body's endogenous insulin are the thiazolidine dinones, and they're also referred to as the TZDs, as I mentioned. On average, they decrease the HbA1c about 0.6 to 1.3%, and all of these numbers that I'm citing are as monotherapy. When you get into combination therapies, it's not always the case where you can just add these averages together. Sometimes you don't see that big of an additive effect. For example, an agent that in itself decreases the A1C by 1%, when used in combination with another agent that decreases by 1%, won't necessarily cause a 2% decrease in the A1C in combination. It may only cause a 1.5%. So as you're interpreting these percents, please know that they're not necessarily additive with combination therapy, but just meant to give you a little bit of an idea of the average effect that these agents have on a patient's A1C. So within this class, we have two agents, rosiglitazone and pioglitazone. Troglitazone was a third agent in this class, however, it was pulled from the market some time ago due to significant cases of hepatotoxicity. And we haven't seen this degree of hepatotoxicity with rosiglitazone and pioglitazone. Now, these agents have a unique mechanism of action, and they reduce cellular insulin resistance by interacting at the receptor level. And the receptor that they interact on is the paraxosome proliferator activated receptor gamma, or referred to in the literature and in conversation, because no one wants to say that long name, as well as PPAR gamma. So you'll hear TZDs and PPAR gamma. What this does is increase muscle and liver glucose utilization. It increases insulin secretion in response to glucose in patients with decreased glucose tolerance, but there's no effect on insulin secretion. Again, these agents improve the patient's endogenous insulin, but unlike the sulfonylureas and meglitinides, they don't increase insulin secretion. It may require up to 3 months to see maximum effect from these agents. One counseling point is that your premenopausal anovulatory female who is anovulatory due to insulin resistance may again ovulate. So for patients who haven't had a menstrual period and suddenly start having them again, this is something you want to warn them against so that they're not surprised. The TZDs have been associated with weight gain, and that's an average of about 5 kilos over 2 to 3 years, and then a possible plateau at that point. But that's decently significant, so again, something to consider in your obese patient. One unfortunate factor for the TZDs is that they have been shown to cause intracellular fluid accumulation, which can result in edema, and we'll talk about this a little further on the slide discussing patients who should not receive these medications. And to point out that they are almost exclusively hepatically metabolized by the cytochrome P450 system. Because of this hepatic metabolism, it's important to avoid this therapy in patients with baseline hepatic enzymes greater than 2.5 times the upper limit of normal. For similar reasons, patients with uncontrolled hypertension, you may want to consider not using these agents. Now, this is different from patients with controlled hypertension. But if you're constantly increasing a diuretic in a patient, remember that these can cause fluid accumulation and cause some edema. So you may consider changing their antidiabetic agent from a TZD to an alternate agent if you find that you're constantly increasing or in need of more diuretic. For the same reason, they should be avoided in New York Heart Association Class 3 and 4 patients because of that fluid accumulation, or any heart failure patient requiring diuretic therapy. There have been studies showing an increased risk of fluid retention when a TZD is combined with insulin in CHF patients, so we really like to try to stay away from these agents in heart failure patients. Unfortunately, the fluid that does accumulate in these patients doesn't respond well to diuresis, but it typically does subside with withdrawal of the TZD. A New England Journal of Medicine article, actually a couple of studies published in the New England Journal of Medicine, have actually called cardiotoxicity into question for these agents. Studies have shown in certain patient populations there's an increased risk for myocardial infarction, and I put a question mark there simply because some of the sub-analyses are still kind of trying to hash this out. But it was a strong enough concern for the American Heart Association to release a statement, and the current studies were done with rosiglitazone, so whether or not it can be extrapolated to pioglitazone at this point is not understood. However, the AHA states, the issue of rosiglitazone's effect on the risk of heart attack and death from heart disease in patients with diabetes remains unclear but troubling. You should discuss the risk with your physician if you're taking rosiglitazone and/or have diabetes. More studies designed to address the specific issue should be done. So how do I interpret this type of a statement? Well, if I think my patient has underlying cardiac disease or is at an increased risk for a myocardial infarction, with the available data, I probably would not use a TZD as first-line therapy for that patient. We're going to now switch to discuss another class, and this class works by modifying intestinal absorption, and those are the alpha-glucosidase inhibitors. And within this class are acarbose and miglatol. Unfortunately, with these agents alone, you only see a small improvement in HbA1c, but they do act well to decrease postprandial hyperglycemia by 30 to 60 milligrams per deciliter on average. So that's really their niche in your patient who has elevated postprandial sugars. How they work is by inhibiting intestinal alpha-glucosidases, and these enzymes are responsible for converting carbohydrates into monosaccharides. So if we inhibit that conversion, there's a slower absorption of glucose and a slower rise in postprandial glucose. And they should be taken with the first bite of the meal because they're really responding to that carbohydrate load from a meal. So taking them if you're not going to eat really doesn't offer any benefit for your patient. As with the other classes that we've talked about, there are patients in whom alpha-glucosidase inhibitors are not optimal therapy. The obvious one, as you're seeing repeated over and over again, are type 1 diabetics. Type 1 diabetics need insulin, not oral therapies. Patients with severe renal dysfunction, and here defined by a serum creatinine of greater than 2, and that's because miglatol has extensive renal clearance. Acarbose does not have renal clearance, but it hasn't been studied in renal failure patients, so we can state on the whole that patients with severe renal dysfunction shouldn't be prescribed these agents. And finally, baseline hepatic enzymes greater than 2.5 times the upper limit of normal, those patients shouldn't be on these either. And it's not due to hepatic metabolism, because we mentioned above that they're extensively renally cleared, but due to occurrence of elevated hepatic enzymes in the acarbose studies, where about 15% of the patients saw an elevation in their hepatic enzymes. So for someone with a healthy liver, that may not be significant or bothersome, but someone who has baseline hepatic function, that might be something that would be more severe in implication. These agents are often limited by side effects, and many patients will come back to you stating that they're not willing to work through these side effects. I think that unfortunately, some of these GI side effects can be kind of compromising, and they occur in a great number of the patients. You see flatulence, bloating, and diarrhea in about 70% of patients. So for that reason, they're contraindicated in conditions that may be exacerbated by increased intestinal gas, such as irritable bowel disease or any other digestive disorder, bowel obstruction, or your severe gastroparetic patient. So if you have a patient with severe diabetic gastroparesis, even if their postprandial sugars are what you need to target, I would argue that these agents probably aren't your best choice simply because of the increased bloating and gas retention for these patients. That could be quite uncomfortable for your patient who already has a slow gut. We'll now discuss the agent that has the newest mechanism of action of the oral antidiabetic agents, and that's a DPP-4 inhibitor called sitagliptin. I'm going to briefly discuss the mechanism of action, and you can realize that it's different than anything that we've talked about thus far. So how sitagliptin works. Well, baseline, following a meal, your body releases incretins, such as glucagon-like peptide 1, or GLP-1, and glucose-dependent insulinotropic polypeptide, or GIP. So food triggers release of GLP-1 and GIP from the intestine. Those two agents then increase the production and release of insulin from the pancreas. And GLP-1 also reduces pancreatic glucagon secretion. So what sitagliptin does is inhibit the enzyme DPP-4 that degrades GLP-1 and GIP. So you essentially have GLP-1 and GIP circulating for longer periods of time and not getting broken down by their metabolic enzyme. So you have their results of their actions longer. So you have more insulin being released from the pancreas, which is one way of controlling hyperglycemia, and you also have a reduction in the pancreatic glucagon secretion. And reducing glucagon secretion then results in lower blood sugars as well, because if you recall, glucagon in its natural physiology acts to increase blood sugar. So if we're reducing the amount of glucagon, we're decreasing blood sugar. A little bit about the pharmacokinetics of sitagliptin. It's minorly hepatically metabolized, and it doesn't appear to influence the P450 system, so drug interactions on that level are few, if any. It's 80% excreted unchanged in the urine, and just to give you some perspective, an average HbA1c decrease is approximately 0.7%. And really what we're defining the role of this agent is it's another alternative for add-on therapy. Typically, this agent, as with some of the other agents that we discussed that have only modest decreases in hemoglobin A1c, really aren't appropriate for monotherapy. You're not going to get good control for your patients with these agents, but they do offer an alternative for add-on therapy. One thing to consider, since this is a new agent, it's probably one of the higher cost agents available at this time. So I've put together these last couple of slides to act sort of as a summary and help you focus on how to choose an agent for your patients. Now, of course, you want to go back to the evidence-based guidelines as well and keep up with those. But as you get your patient in a primary care setting, this is somewhat of a simple decision tree, and there's plenty of other factors, as we've discussed throughout the course of the lecture, that go into selecting an agent, such as some of those reasons to avoid specific agents. However, this is a nice summary slide that I think will help tie us all together and kind of get on the path of how to choose initial monotherapy with an oral agent. What I think of when I'm thinking of these agents is, do I have an obese patient or a non-obese patient? Because we discussed that there's some differences in weight gain among these agents. So if your patient is obese, metformin probably is your preferred agent since it's weight neutral, or there may actually be some weight loss associated with metformin. An alternate to metformin, if it's contraindicated for your obese patient, say that patient has renal failure, etc., would be a thiazolidinedione, or TZD, however, keeping the cardiac issues in mind with that currently, versus a sulfonylurea. So again, if a patient can't take metformin or didn't tolerate metformin and they were obese, then you go to your second line agents. For For your non-obese patient, probably the most cost-effective HbA1c lowering agent is your sulfonylurea. So if you're not concerned with a little bit of potential weight gain, that's probably your agent of choice, with your alternate agent then being metformin. As with hypertension, many diabetic patients aren't controlled on monotherapy, so then we're stuck going to a combination therapy type picture. So this little flowchart sort of helps you break that down on a very simplistic level. So if you have a patient who still has elevated blood sugar, and that elevated blood sugar is mostly in the form of fasting glucose, then I would say you should add a sulfonylurea plus metformin, or alternatively add a TZD. If your fasting glucose is at goal, but your postprandial glucoses are elevated, that's where you may see some benefit from an alpha-glucosidase inhibitor or a DPP-4 inhibitor. So again, targeting where their blood sugars are elevated will help you get the biggest bang for your buck when it comes to choosing one of these agents. Now, we've talked about oral agents in this lecture, and we've said how none of these agents are for type 1 diabetics. They're only for type 2 diabetics. I don't want to leave you with the conception that type 2 diabetics don't ever go on insulin, because frequently they do, commonly they do. And so I've noted here in the bottom left box that combination therapy with bedtime long-acting insulin, as well as metformin plus NPH or glargine, or sulfonylurea plus metformin plus NPH or glargine, those are also options if your blood sugars still aren't under control. So don't think that you just stick to the oral agents. You can always introduce insulin in combination with these oral agents. What the oral agents can do in some cases is reduce the amount of insulin that your patient will have to take. That concludes the first part of our lectures on antidiabetic agents, and I invite you to join me for part 2, which is the pharmacotherapy of the injectable and inhaled agents. And with that, I would also invite you to post any questions about this lecture or any of the readings on the Ask the Pharmacist link. Thanks a lot.